You know that feeling when you're trying to make a pretty simple decision, like maybe you're just trying to buy a new toaster online,
Oh, yeah. The endless scrolling.
right? And suddenly you've got like 20 tabs open, 3 comparison spreadsheets, and you're just completely paralyzed by all these reviews and unboxing videos.
You basically acquire so much information that you feel less equipped to choose than when you actually started.
Exactly. Well, I mean, it's kind of the defining struggle of the modern information age.
It really is. We're totally saturated with data, swimming in metrics, but somehow we're completely starved for actual clarity.
And so, if that's frustrating for buying a toaster, imagine what it's like when the decision is about a human being's health. Because there's this massive irony happening in modern medicine right now.
Yes. The data rivers.
Right. Health systems globally are generating absolute rivers of data. We're talking community health workers logging every single encounter on tablets, rural clinics tracking daily metrics, massive national vaccination programs. I mean, the amount of data is just staggering.
Oh, for sure. The servers are full, the pipelines are flowing, the tech infrastructure to capture all this is basically built.
But, and here's the kicker, clinical decisions aren't actually getting any better.
No, they're really not.
All this data is supposed to make healthcare smarter and faster, but instead it's just creating this overwhelming noise for the doctors and nurses on the front lines.
Which brings us perfectly to the source material we're looking at today.
Yeah, we're diving into some incredible insights from a recent panel at GTEC's Future Health Morocco 2026. It was moderated by Ousmane Diallo, who wrote The Cognitive Revolution.
It's a phenomenal discussion. Diallo brought together these leading minds working on the front lines of clinical tech, specifically in resource-constrained areas across Africa.
Right, to talk about why these highly praised AI systems just keep falling flat in the real world. So, okay, let's unpack this. Our mission for today's deep dive is to figure out why healthcare AI keeps failing what I call the so what test.
The so what test, I like that.
Yeah, because we want to see how a totally new mindset might be the only way to save clinicians from drowning in data. Right now, deploying AI in healthcare is like giving someone a fire hose blasting at full pressure when they just asked for a glass of water.
That fire hose analogy is honestly perfect because it highlights the core theme from the panel. Data without a specific decision focus is just expensive noise.
Right.
It creates this illusion of progress without giving a single ounce of actual clinical value.
So to fix this, we first have to look at how health systems have been, well, failing to fix it so far. It's this trap of just trying to make data look prettier.
Ah, yes, the dashboard trap.
Exactly. Diallo brings up Dr. Jean-Serge Dimitri Diatara. He's the Director of Information Systems for Burkina Faso's Ministry of Health. And she actually has a problem Silicon Valley would envy.
He has way too much data.
Way too much. He oversees digital health tools across this huge resource-constrained system. And initially, they took all this data from malaria clinics and maternal health programs and dumped it into this massive system called DIS2.
And let me guess, they just gave everyone a login and said, go find what you need.
That is exactly what they did. Here's the data, go nuts. Which obviously was a total disaster. Nobody could extract anything useful.
It's just too scattered.
Right. So their first fix was to build dashboards, all the bells and whistles, modern charts, interactive histograms, color-coded pie charts.
They probably had big meetings to show off how digital they were.
Oh, totally. But Dr. Ouattara was incredibly blunt about it on the panel. He called the whole thing a complete failure.
Which is such an interesting point. If the data is accurate and the design is clean, why did it fail?
Yeah, I actually struggle with this a bit. Like, if I'm a clinician and I see a beautifully designed graph showing a fever spike, shouldn't that instantly help me? Why is it a failure?
What's fascinating here is the fundamental flaw in how we think about the brain's capacity. We constantly confuse having information with having the capacity to act on it.
Oh, I see.
When you show a doctor a dashboard with 15 graphs, you're still making them do the heavy cognitive lifting. They have to look at the fever spike, cross-reference it with supply chains, remember the patient's history, and synthesize all of that.
Right. So the system is answering, what data do we have, instead of what do I need to do right now?
Exactly. A doctor with a sick patient doesn't care what's on your server.
It's like looking at the dashboard of a commercial airplane when you're just driving home and want to know if you need to buy milk. It's totally mismatched.
Precisely. Tech should reduce cognitive load, not increase it.
So Ouattara's team realized this, and they went back to the drawing board. They actually sat down with the clinicians and asked, what indicators actually matter to your workflow?
They did the classic user-centered design approach.
They did, But it still wasn't enough. Even with user-focused dashboards, there was still too much raw info. The doctors liked the design, but they still couldn't act decisively.
Which leads to a really major breakthrough in systems thinking. Dr. Oatara's team realized they had to completely flip their engineering process upside down.
Yeah, he calls it the inversion, right?
Yes, it's a radical departure. Usually tech says, let's collect all the data and figure it out later. But the inversion means you don't even look at the data at first.
Wait, really? You just ignore it?
Completely. You start by asking, what specific clinical problem are we trying to solve? And what exact human decision needs to be made?
So you define the decision first.
Right. And only then do you ask what specific data is necessary to support that one decision. Everything else gets tossed.
Wow. So what does this all mean? Well, if you're listening right now and you build or even just use tech, ask yourself, are you just hoarding data because you can?
Most people are.
Yeah, building complex spreadsheets just to show off numbers.
Yeah.
But if you're not designing for a specific action, you're just creating noise. You have to build decision support systems, not just information systems.
It's a brilliant forcing function. It forces rigorous justification before you write a single line of code. If you can't state how a decision will be improved, you just don't build it.
But that brings up a really tricky tension. If we focus on making better decisions, what happens when we ask an AI to make a clinical decision, but it lacks the human context?
This is where we crash into the limits of statistical reasoning.
Yeah, Diallo brings in this incredible example from Professor Mehdi Soufi. He directs a major university hospital in Agadir, Morocco. They've been piloting AI diagnostic tools since 2023, specifically for lung CT scans.
A very common AI application, yeah. It spots microscopic nodules.
Right, so the AI looks at these scans and flags things. And in some cases, it looked at lung nodules and said, these are safe, low probability of danger, send them home and recheck in 6 months.
Sounds efficient.
Except when human radiologists reviewed those exact same safe scans, they found actual cancers. Cancers the AI was just going to let sit for half a year.
Now, the mechanism of why that happened is crucial. It wasn't because the AI couldn't see the pixels. It had all the high-res image data.
Wait, I have to push back on the prevailing narrative here. We're always told AI is vastly superior because it processes thousands of scans a second without getting tired. How did it miss cancer if it had all the data?
Because its blind spot was the patient themselves, the AI lacked the holistic context. It didn't know the patient's smoking history.
Oh, wow.
Yeah, it didn't know their family history of cancer. And crucially, it couldn't read the patient's own anxiety level about waiting 6 months. The AI just saw a shape and applied math.
So a human doctor sees a terrified patient who has smoked for 30 years and says, we can't wait 6 months, we need to intervene now. But the AI just doesn't know that.
If we connect this to the bigger picture, it highlights this terrifying tension between system efficiency and clinical judgment. Professor Soufi says you have to filter out the negatives with AI.
But how do doctors do that when hospital administration is pushing them to go faster? If success is measured by how many scans you do in an hour, how do you find time to step back, ignore the AI, and consider the patient's anxiety?
You often don't, and that's the true danger. The temptation is to just trust the algorithm, click approve, and move on. Human nuance is the first thing sacrificed for efficiency.
And if that's dangerous for a highly trained doctor, what happens when we push these flawed, context-blind systems directly to patients? Patients who rely on them for survival.
The stakes become deeply personal then.
Yeah, Diallo's panel tackled this with Rabia Kozine. She survived cancer, left her job leading digital transformation for South Africa's National Railway, and built Anixi Health, which is a chronic illness platform.
She understands the patient perspective in constrained environments incredibly well.
She really does. She pointed out that in Africa, 40 to 50% of patients struggle with medication adherence. So tech companies parachute in and say, let's build an app with push notifications.
It seems like a very logical, scalable solution.
But she says her biggest fear is dependency. If you build a system to manage their meds, they rely on it entirely. Then the power grid fails, or they lose cell service, the app goes down, and they forget their medication.
Right. Did you actually help them, or did you strip away their self-management skills?
Exactly. Did you just compound the problem?
You've basically replaced a human habit with a tech crutch. And crutches break. Reliability risk isn't just a software bug, it's a patient missing heart medication because they outsource their memory to an app.
And here's where it gets really interesting. Kozine lists several unpriced risks of AI, but the trust risk really stood out. In rural Africa, you might have one doctor for every 2,000 patients.
So access to a human opinion is a huge luxury.
Exactly. So what happens? The app becomes their only trusted partner. It's like when people blindly drive their cars into a lake because the GPS told them to.
They trust the machine over their own eyes.
Right. Now imagine a vulnerable patient with no doctor for 100 miles. The app becomes this infallible oracle. If it says their symptoms are fine, it must be true.
That is precisely why Cozion warns that we absolutely cannot rely on algorithmic direction alone. Human clinicians have to remain in the loop of how info is interpreted.
You can't code empathy.
No, you can't. You cannot automate context.
So we have all these traps. Dashboards causing overload, AI blind spots missing human nuance, psychological dependency risks.
Yeah.
How do we actually know if we're getting it right?
We have to look at the metric that actually matters. And Diallo's panel turned to Amin Moussaoui for this.
Right. Moussaoui manages Morocco's blood transfusion systems. And with blood, speed is literal life or death. Blood has a strict shelf life. Matching must be perfect.
And in that environment, he provided this amazing metric. He said, every unnecessary minute is time stolen from the patient.
I love that framing. Time stolen. But the brilliant part is what he's not measuring.
Hmm.
He doesn't care about IT metrics. He doesn't care about server uptime or processing speed.
Because those are IT metrics, not clinical metrics. His entire focus is optimizing clinical time and patient safety.
It's not about if the software runs fast. It's about if it helps the clinician work calmly in a crisis.
And he argues you only get that if you align the tech, the business processes, and the user's workflow.
If they aren't in sync, the servers don't matter. But when they are aligned, something amazing happens. The system becomes invisible.
Invisible. That is the ultimate sign of success.
He literally said, the day clinicians stop talking about the information system is the day we have succeeded. Tech shouldn't feel like logging in and clicking menus while a patient is bleeding.
It should just be a natural extension of the doctor's brain.
Yes. It shouldn't demand an ounce of extra cognitive attention.
This raises an important question for all of us, honestly. Look at the tools you use every day. Do they demand your attention? Do you spend time managing the tool itself?
Right, troubleshooting the interface.
Exactly. Or does it quietly, invisibly support your workflow? If you're constantly talking about the system, it's failing you.
The tech should just get out of the way. Man, this has been an incredibly eye-opening journey. We started with Dr. Rui Kotara drowning in dashboards in Burkina Faso and learned about the inversion of putting decisions first.
We saw the dangers of AI blind spots in Moroccan hospitals where an algorithm missed cancer because it couldn't see a patient's anxiety.
We looked at the hidden risks of patient dependency with Rabia Cozion in South Africa. And we ended with the realization from the blood transfusion system that the absolute best AI is completely invisible.
The through line is undeniable. The massive proliferation of data creates this illusion of better medicine. But data without a decision focus is just noise.
It's a distraction from patient care.
And a really expensive one.
Which we literally cannot afford. And as we wrap up this deep dive, there's one final thought I want to leave you with, based on a tease of Ousmane Diallo's upcoming work.
Oh, right, the cultural piece.
Yeah. We just talked about how hard the technical side of AI is. But what happens when we zoom out and factor in cultural differences? How is an AI's cold recommendation received by a patient in one culture versus another?
That's a huge unknown.
If we already know algorithms fail when they can't see anxiety, is it possible that emotional intelligence is actually healthcare AI's hardest, most unsolvable problem?
Can we ever really teach a machine to understand how we feel?
It's a massive question. Think about that as you go about your day. Until next time, keep questioning the data.